Dr. Mott.
Thank you. And I'm just checking the sound. Are you guys getting a lot of feedback?
Yes.
Do we have anyone from AV who can turn the feedback on this down? And how does it sound in the back now?
Mine's fine.
Okay. Let me know if you run into any issues. So, I know there's nothing more exciting than talking about legislation in EMS, but ultimately this is about patient care. And so I want to lead this lecture off by presenting a case that I imagine you've all seen at some point in your careers. So, a 32-year-old male with a past medical history of depression, and you're dispatched with the chief complainant of suicidal ideation. Vitals are as you see them. There's no reported overdose, and he's feeling suicidal. I'm going to ask for participation. How many of you feel that the best possible destination for this person is to leave him there in his house? That's your response. How many of you feel that a place like Elhan Place might be the best place for someone like this? How many of you feel that the emergency department would be a best place for someone in this situation? Okay. What about taking this patient to a psychiatric facility? And obviously that's a leading question, but that's what we're talking about is breaking this model where I'm going to go out on a limb here and say you've all been in the position at some point in your careers, if not in the last 24 hours, where you came to a call and you're like, this person doesn't really need the emergency department, but I really don't have any other choice. Like, I just got to take it. And so what this bill is about doing things that are in our patients' interests, that wisely use the resources that we have. So we're talking about House Bill 1721. So this was approved by the legislature initially in 2015, and implementation in 2016. And what we have coming online now that makes this possible, we actually have facilities now in Clark County that can accept these patients from the field. And so we're opening this alternative destination up so that we can do the right thing for our patients and for the system as a whole. So the House bill provides definitions, it specifies what EMS needs to do, it gives a screening tool, an operating procedure, and then it provides for EMS education that we're doing right now. So this is what I want you to take home from this lecture. You have this ability, and we trust your judgment. And there are guidelines, but the guidelines are never going to be a substitute for your judgment. There's a lot of clinical experience in this room. And what I want to talk to you today is how you're going to apply that experience, how you're going to use the guidelines so we can do the right thing for our patients. And then I'm going to point out the key things that you're going to want to document, because as you can imagine, this is one of the, probably the highest risk thing we do in EMS is leave someone at home. Taking them to a facility that cannot treat an emergent medical condition is one of the next highest risk things we can do. And so this is something that we're going to want to document very thoroughly and hit some key points. So these are the considerations in the bill. If they're a medical emergency, how severe is the mental health disorder? What risk is there? And then what are the training that EMS providers need to be able to make this triage decision? So it gives definitions of a mental health center. So a crisis stabilization unit, it's short-term care that's similar to something like Elhan Place. The triage facilities, and then evaluation and treatment centers, which can provide inpatient care. These mental health centers can receive patients from law enforcement or mental health professionals, and what we're opening up the door now is to allow them to receive patients from EMS. There are also chemical dependency centers, like sobering centers or an acute detoxification facility or a subacute detox. this is what's changed. In Clark County, we now have 2 facilities. So Rainier Springs is near Salmon Creek. It offers inpatient treatment for mental health and drug and alcohol. Ultimately will be a 72-bed facility. My understanding is that not all 72 beds are open right now. And they have designated it to the ambulance entrance. And we're working through the details. We just got an email yesterday that they have gotten through the final hurdles to be able to accept EMS patients. And then there is also NAT opening in January, is that correct, Mark?
No, not till spring.
Okay.
County Crisis Center.
So there's a county crisis center on Lower River Road that's public funded, 22 beds, including 16 stabilization beds, 6 triage chairs, spring 2019, and they're making plans to be able to accept ambulances as well. These are more definitions from the bill. So peace officer can take to a chemical dependency center or an emergency department someone who appears gravely disabled or who is threatening harm to themselves or other people. A designated crisis responder. This is what you may have heard referred to as the designated mental health professional previously. So this is someone, so unlike in Oregon where 2 physicians can hold a patient involuntarily, as a doc in Washington, I can detain someone in the emergency department for evaluation temporarily, but I cannot commit someone to a psychiatric hospital against their will. Washington State reserves that authority for a designated crisis responder. That's a mental health worker. And so we see them in the emergency department, but you also see them in the field. So they get information that a person presents a likelihood of serious harm. They investigate, and they can hospitalize that person against their will. There are also emergency social workers that you will occasionally see in the field. They do not have the authority to detain patients. We always have social workers on duty in the emergency department, and they work with the designated crisis responders, but they do not have that authority to detain patients against their will. But they can refer patients to the DCR. So we're going to go into the definitions of crisis and intervention and give some background on just some reminders on how to handle these situations. So what we're talking about are patients in a mental health crisis. So this is a situation where someone's natural coping mechanisms are not able to handle the situation. This is not 911. And then the job that falls to us is sorting out, is this because of an acute medical problem, or is it just a mental health emergency? So I think this states, it's obvious these are some of the benefits of crisis training, and so I want to use today to just refresh some of the things that you really want to be able to do and document when you're handling patients with a mental health crisis. So there's the recognition piece, physical safety piece, which is crucial, and we want to make sure that we're giving you the tools to come home safely every night. How you can mitigate the crisis and how you can develop the action plan. We want to keep this, your intervention with patients, simple, brief, creative, and we'll talk about some problem-solving strategies about avoiding escalating crisis, and keep these things practical. You are people who can get close to the immediate and stabilize the situation just by your presence. This is mentioned in the bill. These are crisis assessment tools, just some things to think about in the back of your head as you stabilize the situation, acknowledging with the patient that there's something distressing. That means if someone is having schizophrenia and says like, the FBI is listening to my thoughts, you don't have to argue with them about that. You're like, I bet that sucks. You know, I bet you don't want to feel that way. And just you find some place where you can meet them. And then facilitate the understanding of the situation. Well, I hear you. Like, you know what? It wouldn't surprise me if they couldn't hear you as well if you were inside the ambulance. And then help the patient come up with a plan of action, restore functioning, or refer patient to the appropriate facility. This is the SAD person's assessment scale. You don't need to remember every point of this. The reason we bring this up is to just think about because what we're trying to do when we see someone who's potentially suicidal is say, what is the risk that this person is actually going to successfully commit suicide? And these things, each of these things make you more likely to successfully commit suicide. So a good portion of the room gets 1 point. Males are, although women are more, attempt suicide more often, men are more often successful, usually because they use lethal means when they do it. Young patients or, I guess I'm right at the older border here. But young patients, as you get over 45, that is a relative risk factor. If you feel depression or hopelessness, previous suicide attempts, and psychiatric hospitalization, but I would clinically, I really put the emphasis on previous suicide attempts. Asking it, like, have you done this before? What happened? If someone has shot themselves and just through really good trauma care managed to live, there's still a pretty high risk for successful suicide, but they've had a truly lethal overdose. Now, there are patients, particularly those with borderline personality disorder, who tend to make frequent sublethal attempts. But in general, if someone has actually done something in the past to try to commit suicide, they're at much higher risk than someone who's, say, 65 and has had depression for a long time but has never attempted. It doesn't mean they won't, but it makes it relatively less likely. Alcohol or drug use is a huge risk factor for successfully committing suicide, because you lose that impulse control. Losing rational thinking, that feeds into the alcohol and drugs, but some people who are just absolutely overwhelmed, like this is, I've got a DUI now and my life is over and there's no hope I can ever come back from this. When they start catastrophizing, that's part of the cascade that leads someone to suicide. Being single, divorced, or widowed is a risk factor. So the more family support you have, the more connections you feel to the outside world, the less likely you are to commit suicide. If you, in this current episode, made an organized or serious suicide attempt, that's obviously a significant risk factor, and you can see that gives you 2 points. This is adding on to the single, divorced, or widowed, but no social support. And I think this probably feels intuitive from what you see on the streets. I mean, someone who is living on the streets versus someone who is in a crisis situation that has a family who cares for them, a family who's willing to be supportive. That kind of social support makes a huge difference in the risk of suicide. And then saying, my plan is to jump off the I-5 bridge is, relatively speaking, a risk factor. Questions about this? So you get thrown into this situation. Your goal is to take this person who's in this crisis situation and start to build some trust. So any small thing that you can do to de-escalate the situation can make a difference. If you're, if you can safely, say you're not on the street, you can safely turn your lights off and the lights are making the person agitated, you can turn off the blinking lights. Express some understanding. That doesn't mean you need to agree with everything they say, but just some connection like, that sucks. I'm sorry you're there. Discuss the situation calmly and do what you can to lower the tension. And so if you can find even some thread of understanding, some place where you can kind of agree that, okay, well, I didn't, you don't have to say this, but okay, I was asleep and I got woken up at 3 in the morning to come here. So actually we're here. I want to wrap this up as quickly as possible. It's true for you, it's true for the patient. Work with the patient to make a plan. Take what's positive in the patient's response. So, I don't want to be here. I don't want to be in this situation. Well, let's work. How can we make this happen? How can we get you out of this situation? Suicidal impulse. You tend to get called at the point where it's peaking, and they do tend to decrease over time. Anything that you can do to slow the situation down, to take some of the tension out of it, will give you more time to work. So you're going to assess the crisis as best you can, establish the rapport, figure out what the problems are. That doesn't mean you need to understand everything about their father, but get some sense of what is it? I mean, is this because your girlfriend just broke up with you? Is this what is it that's leading the person in this situation? Try to get some sense of, just some rough sense of where they're coming from, and then talk through the alternatives and come up with a plan for this patient. This becomes particularly important, as we'll see later on, because to get a patient to a psychiatric facility, they need, directly from the field, they need to be voluntary. So you're trying as much as possible to get their cooperation. So you're assessing the situation and then moving on to make a plan from there. Most people, I think, will respond well to a uniform. Occasionally, we've all run into people who respond negatively to the uniform. But just some level of personal contact. I'm a huge fan of just putting a hand out. And if the patient is signing you, they won't shake your hand, that really signifies to the bystanders, but look, I came, I was peaceful, and this person is just really agitated. Sometimes just listening to the patient rant for a little while can be helpful, and they're like, okay, well, I'm gonna get a chance to speak without getting interrupted. I find that it's really helpful, particularly if their drugs involved, saying, look, we're not here to judge you, we're just here to take care of the situation. Be professional, get on the eye level, speak calmly. And when we talk about exploring the problems, exploring the feelings and emotions, I say that I don't need to know everything about what's going on, but can you tell me what kinds of things are bothering you? It helps me just to figure out, okay, is this about relationship stuff, money stuff, or it just gives you some idea of where they're coming from. But you want to keep this focused, you don't want to let this drag on forever. What happened? Have you been in this situation before? What happened the last time? Try to find some way to connect it as best as possible, as if it were your family member, or if you can picture yourself in a situation like that. What would help you get through this? And then you're going to be exploring the alternatives. So, and this is part of getting that patient's cooperation. If a psychiatric facility is the most appropriate destination for this patient, well, one option is we can take you to the emergency department. Another option, you'll go there, you'll see a doctor, there probably will be some waiting involved, and then ultimately they may end up getting you to a psychiatric facility. Another option that we have is to get you directly to the psychiatric facility. And then you're going to work on an action plan with the patient. Now, obviously, these are the patients who are not intoxicated, who meet these criteria, and you can get some buy-in from them. Hey, this is really what would help you. Some may agree to a medication. We'll talk about how that plays into it. So let's talk about how you're going to assess and categorize the patients. Before we go into this, any questions to this point? So who is not a good patient to go to alternative destination? Confused, abdominal vital signs, combative, if they're showing signs of alcohol withdrawal like tremors, diaphoretic, having seizures, or if there's some concern, this is really where your clinical judgment comes in. Because we've all get around that patient who is suicidal and they're so committed to it that they're really not being forthcoming with you. And so that having that whole clinical judgment, could there be something else going on here? Should be in the back of your mind. So you're going to take your exam history, get some sense of what's going on, particularly with their psychiatric medications, and then think about what else could be going on here. Challenge yourself. Make each patient prove to you that they do not have a medical emergency. And so in the mental status exam, with these patients, you're going to go a little bit deeper than you would normally go. So just you describe what you see. So this person was walking against traffic completely naked. This person appears disheveled. This person is well-groomed. Describe their behavior. Describe their speech. Is it, my wife is a psychiatrist, and I remember when she was in training, she'd get a call to go in and assess someone, and she's like, they're depressed, this is going to take a while. Because depressed people tend to they have everything slowed down. And so this really withdrawn person who's speaking very slowly is a very different situation from the manic person who, you're a resident? I'm the president, I feel great. And so just describing what's going on with their speech. The mood is how the patient describes the mood. How do you feel? And they're like, well, I feel crappy. I feel overwhelmed. Describe the thought processes. So the person who is so disorganized that they start talking about one thing and then it kind of leads to another thing, it never gets back to the main point. That's being tangential. If they can't follow the thought through, that's something you want to describe. And then the content of their thought. Are they paranoid? Are they suicidal? Do they, I hear voices say, they tell me to kill myself. What are they perceiving? How well are they thinking? Just some basic assessment of, are they oriented? Are they conscious? Do they remember what brought them to this point? Judgment is the classic question they teach you in medical school to ask this is, if I were to give you $1,000, what would you do with it? This is something I think in the field you're probably going to assess mostly by what kind of choices they're making right there in front of you. So does someone, when faced with fire crew and an ambulance crew, start running the other direction, or do they say, I better slow down and talk to these people? Are they right there on the bridge right now? You're going to infer a lot of that from the actions. And then insight is important. How much do they understand what's going on? So someone with good insight is like, I feel totally overwhelmed. I don't know how I'm going to go on. I really feel like I need help. That's someone who has really good insight versus someone who is like, I feel great. I haven't slept for 3 days, but why would I sleep for 3 days? I like methamphetamine, and methamphetamine feels good. So let me just keep on doing methamphetamine. Do you have any methamphetamine? And so how much do they understand what's going on? And that's something that you just pick up in this conversation. This is an abbreviated version. Whatever it is, but just have some way to think about hitting the key points in the psychiatric exam to documenting how are they speaking, what's their emotion like, what do they look like, how alert are they, and then what is their posture. So what are the potentially life-threatening behavioral emergencies? Obviously suicide. There's uncontrolled rage, this person who's out of control, as differentiated from excited delirium, who's someone who is exhibiting superhuman strength. That's the person who's naked walking into traffic, and you come up and there's 6 law enforcement officers on this person and he's still fighting. Drug intoxication, drug withdrawal. Any volunteer come out, what does it mean to be gravely disabled? What's
Not
that?
survive that assessment.
Yeah, so the answer was would not survive without assistance. They're essentially getting to the point where they can no longer care for themselves. And this is a much more difficult call, but that can be an elderly, demented person who's living at home and who's not able to get their meals or attend any of their activities of daily living. So we talked a little bit about some of the risk factors for suicide. The key things I point out here are that making arrangements, doing something in advance, that's something that's not captured in the SAP person scale. But you're going to get this idea of how serious are they about this? What are they doing in the period leading up to this? So with the suicidal patient, secure the environment. So what is the single biggest risk factor for a successful suicide? Previous attempt to the single biggest modifiable one is access to a firearm. Guns are a really effective way of killing yourself. And so, so just think about the environment. Think about what can you do to both separate this person from any potential weapons in the house, and how can you make sure that this person doesn't have weapons. Develop the trust and rapport, as we talked about, do the risk assessment where you're trying to get some sense of what are the things that lead into this. And then you're going to talk about the alternatives in this situation and then work with this person on an action plan. And we'll talk about what can be appropriate to sell it. So alcohol is a huge problem, something that we see every day. This can really complicate the assessment of a suicidal person. And in general, unless we're confident that this person is not currently either intoxicated or withdrawn, it's really difficult to get a full mental health assessment. Remember the timeline for alcohol withdrawal. So if someone is just 6 to 12 hours out from the last drink, the symptoms tend to be fairly mild at that point. Now, if they've been cutting down, say they've been cutting down over the last 24 hours, and even they're only 2 hours from the last drink, but they're getting too much blood in their alcohol system, they're going to start to feel some of these things. 12 to 24 hours is when they can start to have the hallucinations, and then 24 to 48 hours is when things can get really bad. And then in the 48 to 72 hours, that's where they're at the highest risk of delirium and they get the vital sign instability. And so it's fairly rare that you're getting contacted at this point, but there's something. Remember that these things are going to progress, and try to get some sense of how much that could be playing into this patient's presentation. Cocaine and methamphetamines. So I'm bringing up all these things. I know you're familiar with these, see people using these on a daily basis. I just want to plant this in your head as we're thinking about these patients. Could this be, how much of this could be due to drug effect? Remember that typically with this, you're going to get some vital signs clue that intoxication with this symptomatic is part of the mutation. Most typically tachycardia. PCEP is fairly rarely used. More often you may see someone using ketamine if they can get hands on some of ours. So you're familiar with that. Opioids are a very, very common problem. And so you know how to recognize an opiate overdose. Opiate withdrawal is not life-threatening in the same way that alcohol or benzodiazepine withdrawal is. But if they're having significant withdrawal symptoms, that can start to cause vital sign abnormalities, and those can be patients who will do less well at a purely psychiatric facility. The sedative hypnotics and then some miscellaneous ones. Obviously, we're seeing pretty common use of marijuana. I'm trying to remember the last time I saw a urine drug screen that didn't have marijuana. It's kind of like getting your official Washington State citizenship. Other hallucinogens like mushrooms and inhalants. And the big clinical clue that you get if someone might be abusing inhalants is that you're going to tend to see some kind of gold or silver paint around or around the mouth on their nails. So consider the fact that there's psychiatric medications on the presentation. So especially patients on the older antipsychotics, medications like Haldol, they get a dystonic reaction with akathisia, that was an involuntary mouth movement. The SSRIs, medications like Prozac, in the first 2 to 3 weeks, there's actually increased risk of suicide. And so someone who's recently started on that is a relatively higher risk. Thankfully, those medications are pretty benign in overdose, but it's definitely a risk of starting those medications. And then many psychiatric medications affect the serotonin system. We'll talk a little bit more about serotonin toxicity later. And then especially the tricyclic antidepressants can cause this prolonged QRS by blocking sodium channels. So serotonin toxicity is increased serotonergic activity in the brain. This typically comes when you get a couple of different serotonergic medications adding up. So the SSRIs, medications like Prozac, Effexor, the most common antidepressants, they're selective serotonin reuptake inhibitors. So they result in more serotonin being around. Well, Zofran also works through serotonergic receptors. And so this can be a patient who's on an antidepressant, they just had a GI illness, and then they're taking Zofran around the clock. There's a very famous case in medical training, the Ruby Zion case, which resulted in work hour restrictions for the residents. But it essentially involved a young girl who was on a couple of medications that affected the serotonin system. And so essentially what you get is tachycardic, hyperthermic, and really ramp, and then they ultimately just get super high fevers, and then ultimately seizure, coma, and death. And so you really need to know all the medication interactions, but getting the medication history and being attentive to the vital signs, that's the way you're going to pick something like this up. So it looks kind of like a sympathomimetic overdose. The big clinical feature that the way that we can help figure out is clonus. So they either have super brisk reflexes, which happen, their arm bounces back. Or clonus is when you check their patellar reflex, and then that also keeps contracting. Or you check their patellar reflex, you push their foot up, and their foot keeps beating like that. And that's a sign that you're seriously disinhibiting the upper motor neuron. It's not something I expected to check for in the field, but it's part of the reason that we ask you to be really attentive to the vital signs in this overall presentation and the medication history, because that's the way you can pick this up. It's fairly rare, and it's a difficult diagnosis to make, but that's part of the reason that being attentive to the vital signs and the skin signs is so relevant. And then, particularly in the upper limits of the age range, one of the questions you're going to be asking is this delirium, medical condition versus dementia? And so, again, the thing that I key on clinically are the vital sign abnormalities. It is fairly rare to have pure dementia with no medical problem and to have vital sign abnormalities. With delirium, there's typically at least one vital sign abnormal. Delirium tends to be much more waxing and waning, whereas dementia is a much more gradual course. In dementia, they tend to be aware of what's going on. They can have some difficult finding words, but you can generally have a conversation with it. The content might not always make sense, whereas someone with delirium just tends to be incoherent, because they're just not processing. This is a really difficult distinction to make. The vital signs are the biggest group here. But I guess in getting that history about how did this happen, Emma has not been doing as well over the last 3 months. It's a very different presentation than, she is really acting different yesterday and today. So grave disability is the 3 things we can hold someone for are being suicidal, homicidal, or being gravely disabled. It's someone who can't care for himself. And this is the most difficult part about making this distinction is that some people just make really bad decisions, and some people are unable to care for themselves. So this is where the PCRs can be particularly helpful. A few more psychiatric disorders. So anxiety is obviously something that we deal with frequently, but anxiety can be the manifestation of a medical condition as well. So, and this can be a really difficult distinction to make, both in the field and especially in the emergency department. And so you can think about how sepsis would present, especially people who are having an MI tend to be anxious. Tachycerebral cardiomyopathy, the broken heart syndrome, there can be tremendous emotional stress that actually leads to abnormalities with heart motion, elevated cardiac enzymes. Respiratory failure can be difficult to distinguish from anxiety. Your end-tidal CO2 can be a clue, oxygen saturation can be a clue, but again, you're making these patients prove to you that they don't have an emergency medical condition. PE, CVA, or more often brain injuries. I reviewed a case within the last year, someone who was thought to be intoxicated, was at the casino, fell down, and just wasn't acting quite. Ultimately had an alcohol level of 0 and an intracranial hemorrhage. So a thorough exam to look for signs of trauma and history. So the overdose and drug interactions. Metabolic acidosis. So essentially, if someone's breathing fast, you want to make sure you think of all the other potential causes before you make the conclusion that this is fast breathing just related to anxiety. Anaphylaxis can show up with anxiety. Typically, you're going to get some other findings. Dehydration can manifest, but typically you're going to see some skin signs and some history that way. So mood disorders, either depression, low mood, mania, high mood, or bipolar, cycling between the two. Patients with bipolar disorder are at risk both at the highly negative phase and at the depressed phase. And so these are things that you pick up on your mental status exam. Psychosis, which is the biggest category in schizophrenia, which is a specific illness. So psychosis is impaired reality testing, false beliefs, false perceptions, and they tend to have some disturbance in the affect. More often than not, they tend to have a very blunt affect. You just can't engage in them. It's just very, very flat face. Schizophrenia has both the positive symptoms, meaning the things that get added to what you're dealing with normally, the hallucinations, the paranoia, and then the negative symptoms, the things you used to be able to do, you can't do well. And so that's clear rational thought processes. That's where the negative, flat affect is part of that negative, the negative symptoms. They can, to the extreme that they can be catatonic, or they're barely responding to you. And then very common for a patient with schizophrenia, they tend to be disheveled, they lose that ability to care for themselves. So now we're going to move on to thought about these potential causes, thinking about the different things playing into this situation. How are we going to make decisions about this? So these are the inclusion criteria. these are the people who can go to a psychiatric facility. 911 call, 18 to 55 years old. They're volunteer with mental health as the chief complaint. At this point, we are not taking any new onset psychiatric conditions to these facilities. This needs to be someone with a known history of a mental health problem. They need to be willing to go, and that's why to make this efficient use of resources is really dependent on your ability to build a rapport with the patient and convince them that this really is in their best interest. They need to be cooperative. You need to make sure that there's not another medical condition. They need to have a normal level of consciousness. They can't have dementia complicating the picture. They need to be able to do the basic activities of daily living, go to the bathroom, feed themselves, and then have vital signs within the acceptable parameters. So these are the ranges given for vital signs. But again, this is also encompassing your judgment. If you have someone who's on the borderline of every single one of these, and you just have this feeling that something else is wrong, they may meet the vital sign criteria, but in your judgment, this just doesn't deal with the right situation. So you're going to check to make sure that they meet the inclusion criteria. You want to make sure that they don't meet any of the exclusion criteria. And then we'll go through this step-by-step process. So these are the exclusion criteria. So if there's a history of an intentional or an accidental overdose, and that can be whether the patient is reporting it or someone else is reporting it. If there's some global history that says that an overdose is involved in this, the person is not a candidate to go directly to the mental health facility. If they've got minor strains that require bandaging, that's okay. If they need more care than that, then not appropriate. Loss of consciousness or seizure, so a recent syncopal event or a seizure, even with a history of seizures. We want to make sure that those medical issues are controlled before they go directly to the psychiatric facility. We're not taking pregnant patients. We're not taking patients with new onset mental health problems. Again, there's going to be some gray area here, but we'll talk about how you can work. No evidence of acute medical or traumatic problem, and also excluding patients with anticoagulant use. And so remember, that can be both Coumadin or any of the novel anticoagulants. Like aspirin would be okay as long as there's no suspicion of sanitary overdose. So you're going to assess the patient. You're going to see if you can get the patient's cooperation. This might be an acceptable thing. You're going to go through the checklist to make sure that they meet the inclusion criteria and that they're none of the exclusion criteria. At that point, we're asking you to contact the facility to say you have an EMS patient and make sure that they have that available. And then at that point, you're going to contact medical control and you're going to go over this with the doc and you're going to use your clinical judgment together to make sure everyone's in agreement that this is an appropriate patient to go directly from the field to a mental health facility. And then you're going to document the inclusion and exclusion criteria, and that's going to go with it to the facility. You also want to make sure that you document the inclusion and exclusion criteria in your patient care report. It is possible that we're going to come up on some other things. We're still in the early stages of this. So again, we're trying to be efficient where we can. The question is, if you put yourself in the shoes of the medical program director, what would be the biggest way for this to go wrong? Seriously, can you say a little louder?
The transport patients on the exclusion was too,
Yeah, so, not following criteria, getting them, and then especially, and then if there's a bad outcome at that point. So it's, just like, you can have a patient and you're very worried about cardiac symptoms that doesn't meet all the inclusion criteria for STEMI. There are going to be some patients who may, this is, in your gut sense of, this is probably where they're going to end up, but not everything is falling into place, and that's okay. We want to be clear with this. These criteria could change over time, but we're starting very restrictive. We want to make sure that we get this right, because we think both in terms of, think of this in terms of your lives, this is, our goal is ultimately that this is going to get you back in service quickly. But we also, you want to be able to bring patients that have an acute medical condition to hospitals that have beds to care for them. And if we can make even a small impact, because psychiatric patients tend to have amongst the longest length of stay, if we can make even a small impact in the number of psychiatric patients that are coming through the emergency department, that's going to have a significant impact in increase of medical beds available for medical patients in the emergency department. The receiving facility can ask you questions. Making this work is going to be dependent on having those professional, respectful interactions with the receiving facility. As much as possible, you want to bring these medical devices that the patient has. So, for example, if they sleep with a CPAP, that would be a helpful thing to bring to the facility. And as much as bring patient medications that will allow them to do their medication reconciliation and so as much as possible, we're going to bring the stuff that they're going to need to stay there. And then you're going to want to do a full patient chart. I would argue this, in some ways, this is even more important than the patients that go to the emergency department, because this is higher risk destination than taking someone to the emergency department where, if you missed some medical condition, you got an ER doc there who hopefully can pick up on it. So these are things you want to really document thoroughly, and obviously we'll be reviewing these charts to make sure that we're doing that, because we want to make this work. So here's the protocol. Just a recap. Including criteria, minimum diplomatic dispatch, patients in the appropriate age, that they're voluntary, cooperative, non-static, normal level of consciousness with dementia, they can perform activities daily. Not new onset, not a suspected overdose, not trauma that requires another bandaging, no loss of consciousness or seizures, no pregnancy, or I would say, if there's a reasonable suspicion of pregnancy or parents that are not taking the patient, no evidence of acute medical or traumatic problem. This is really where we trust your judgment, and then not on amplified vital signs meeting those numbers. And so you're going to assess the safety of the patient. Obviously, if you're going to use the restraint protocol, this is not a patient that's going to go to an alternate facility. You can assess and treat medical conditions, contact receiving facility, then medical controls, document the inclusion criteria and exclusion criteria provided at the facility. And then we mentioned some of these as we've gone throughout, that waxing and waning level of consciousness. So there's occasionally with it, and then occasionally out of it. That's something that should make you suspicious for delirium, abnormal vital signs, changes in the pupils are often included in intoxication. First psychotic episode, this is going to be captured by the fact that you're going to be getting a mental health history. And then an acute onset over the last couple of days, it should raise your suspicion for substances or delirium. You want to document the things that go into the mood disorder or thought disorder, and make sure that you've done what you can within your ability to exclude these medical conditions. So let's take another case. So a 21-year-old female with prior medical history. She had a little bit of anxiety when she was an adolescent. She's suicidal. And the vital signs are as you see it. So she's voluntary to go. She's not combative. She's not very forthcoming about whether there was an overdose or not. There's not much other history available. What are the things that you want to consider in deciding on a destination for this person?
New onset.
Yeah. So if it's new onset, let's just take those patients out. You've got some things saying the person's anxiety, but you don't have this history of suicidality. This is another case. And these vital signs are within the acceptable parameters. Every single one is in the upper limit of the acceptable parameters. And so there'd be another thing, even if she had that history, just to just give you pause. And again, these are hard calls. These are hard calls in the emergency department. And so what we're trying to do is to carve out those patients that really we can both say that the likelihood they have an emergency medical condition is very, very low. And we think that this is the best destination for that patient. Questions for me?
Yeah, I have a couple. One of them is, what's the maximum time on an involuntary hold that a person can be detained?
The question is, what's the maximum time on an involuntary hold?
Correct.
So you're talking about what what an emergency physician can do, or what the designated crisis responder can do?
Both.
So an emergency physician can, there's not a firm timeline, but essentially we could say, like, I'm not going to let this patient leave the emergency department until they've been assessed by the DCR. Occasionally we will end up waiting some time for them to get there for logistical issues, but it's typically 6 hours or less, and then they get there. And then if we don't have a medical reason to hold them and the DCR doesn't find a reason to hold them, they can't justify holding that person against their will, then our options are essentially done. We can't hold that person against their will. So that's the role that I'm in as an emergency physician. So for the designated crisis responder, once they make the determination that the patient needs to be hospitalized against their will, they have 12 hours from the time that hold is placed and the patient has read their rights to find that person in bed. So the state of Washington has outlawed psychiatric boarding for involuntary patients. So you can't just detain someone indefinitely in your emergency department. They can be detained for 12 hours and then they have to find them a bed. That law came into being, I believe, 3 years ago. That has increased the state has then realized, okay, well, we really need to make sure that we're funding enough psychiatric beds for involuntary patients. And then those patients get priority for those involuntary beds. So it's fairly rare that someone will be held by the DCR and that they can't find them a bed within 12 hours. They can re-detain them, but it has to be based on a fresh assessment. And so I can't think of a time where someone's had more than 2 of those detentions in the emergency department by the DCR or EPA. And typically, because of that law, once they make that decision that that person needs involuntary hospitalization, then that typically happens within 12 hours. Does that answer your question?
It does. Question number 2 was, why is anticoagulants listed on that?
So the question number 2 is, why are anticoagulants listed on there? We're trying to keep this narrow and to make sure that we are capturing patients that are low risk for another medical condition. Particularly with the novel anticoagulants, there's a significant increase in the risk that someone can either have a drug interaction or to have some unrecognized bleeding complication. And so, although that's something that we will reevaluate, but that's we're trying to draw a narrow box to make sure that everyone is safe to go there. That's one of the things that we chose to do. Dr. Weber, do you have any other comments about that?
Because it's also because these are low-level medical facilities, so that they really, if the person's on Coumadin, they don't usually have the ability to check a pro time for them. So, it's a simple thing. It's just stuff that it's difficult to manage medically. Now, one of the things that I may have missed is that, if you make a decision, remember, these people have to be voluntary for you anyway. It's not like police have a different, they can take someone involuntarily. And the mental health, the crisis resource person can can send them to the same hospital or to the crisis intervention center against their will, but you can't. So you can only suggest, and they have to want to go voluntarily. They may, after they've been to see Rainier Springs, which is kind of a boutique place to be, they probably want to go there because it's got a lot nicer beds and all sorts of other facilities. So, but if you get there with the patient and they're going to go through a crisis evaluation and medical evaluation at the scene, although it will be by a nurse to start with, so your evaluation medically may be better, but they will run a blood out. We're not requiring that every ambulance have a breathalyzer, so they will check the blood alcohol or the breath alcohol. If it's above 0.35, they'll send them away. They'll send them to the emergency department. If they have a medical thing that they say they can't manage, they will send them by ambulance to the emergency department. If they, when you call them, they have the option of saying, yes, we can take that patient, or no, we can't take that patient, based on your assessment. And they will not do, at least they told me so far, that they will not do a wallet biopsy over the phone. In other words, they won't ask what insurance company they have. They're not supposed to. Now, that may change. Right?
For the recording, I'm just going to summarize what Dr. Whipper said. What we're trying to do here, identify these low-risk patients. They're going to be screened by a nurse, but these facilities have a fairly low level of both medical expertise and medical equipment, and so we're trying to get this narrow population in. The only thing that I would add to that, we absolutely, because the upper age limit is 55, there's going to be a relatively small number of patients with psychiatric history under 55 on anticoagulants. So hopefully we're not losing too many patients in that way. Two, making this protocol work is going to be absolutely dependent on your feedback. What is operationally working? What is happening? This is a new thing for us, and we're getting to know these facilities. We'll be getting to know these facilities, and so we want to hear what's working and what's not in this protocol. But we think to go back to the take homes, we want to make medical beds available for medical patients. We want to get psychiatric patients to a place that can care for them appropriately, and we trust your judgment to make that call, and we're going to be on the other end of the line to support you in making those decisions. Other questions for me?
Since this is a state house bill, can we transport to facilities outside of the state, like Unity?
No.
Because currently, before we had the ability to select alternative destinations, if we were taking a voluntary to a manual would try to send us via the ear system to Unity. That is, we usually probably pack sand, we take it to a manual, but that was still the case. If we cannot divert from.
These are not patients who can divert.
Other questions?
Well, can you summarize just the process by which a crew in the field gets a patient to Rainier Springs for now and the Crisis Intervention Center eventually? They've already gone through the inclusion, exclusion. Now what happens?
So you've gone through the inclusion and exclusion criteria. You contact the facility and make sure that they're able to accept this patient. Contact medical control and make sure you have the doc on board, and then transport. So that way we're at. Yeah.
And we will be rolling this same protocol, not to this extent, but would be rolling your protocol out to the ER physician so that they know what's expected of them. Needless to say, they're not going to be unhappy with your choices if the patient really does fit the criteria. We're not talking about getting every patient to an alternative facility, so we don't have enough bed space right now. When the crisis center opens, we'll have an increase 24. Greener Springs has a likelihood of 72 beds ultimately, but let's face it, their 24 beds are going to be filled already today. So it's going to fill up. They fill up fast. And because they're taking patients from not just our area. This is a private facility, but they're accepting patients from Oregon, they're accepting patients from California, too, that are coming as a referral basis. And from other places in Washington. State of Virginia, Richmond, Virginia started this several years ago. They went through a state process, and they felt that safely 10% of their mental health patients could be seen at a mental health facility rather than go to the emergency department first. It turned out that their experiences, they ended up ultimately about 40%. Now I'm expecting 10% would make a big dent in our ER activity here. That's, I think, a reasonable goal. I'm not looking at 40%. I mean, we're trying to do this very, very safely. Had a more expensive system in Richmond too. Lots more mental health problems in Richmond, I guess, than here.
Can you just treat them with marijuana?
Yeah.
Just one addition to the question about medical screening. So just for context, in the emergency department, these facilities require us to have labs and urine before we send these patients over there. Even though our professional society, the American College of Emergency Physicians, specifically says that lab test, a focused history of physical is all that's needed, with lab testing as appropriate. And so you essentially are being able to do something that I can't do, which is to send them there without labs. And so that's part of the reason that we're being particularly cautious. And anything that might just require a routine lab check, we're routing through the emergency department. Thank you for your attention. I really appreciate it. We'll come back at 20 minutes after and do case reviews. Thank you. And finally, I'm welcoming Leonard. If you'd like to give feedback on this lecture, you can give it at that address out there on your phone.
Okay, case reviews, but first thing first. Last month, a couple of you brought up a question or an issue about having a death in the field, leaving the patient with the family, and then having and calling the ME. ME says, we'll have the family call the, I'm not going to come out, have the family call the funeral home, and the funeral home says, well, when the family calls, says we can't come unless we've been cleared by the ME. Okay, so I've spoken with the ME, and there is not a policy at the ME's office that they would take care of notification of the funeral home. It wasn't a policy, it was something that Tony and the other older assistant at the ME office would do as a sort of courtesy. Apparently we have a increased burden on the ME's office these days, maybe a lot of deceased persons, but anyway, there's not a policy, and so they have informed the nursing home, they have informed the funeral homes that if they've been cleared, that the family can call and do it, but they need to know, so when you leave a deceased person, call the ME, he says, well, this is not a case that we need to investigate. You can have the family call the funeral home. Just take that person's name down, the ME's name, and give it to the family, so that when they decide which funeral home to call, they say, so-and-so from the ME's office has released the body. Then it's taken care of. So, all right, some case reviews.
So you could kill your neighbor and just call them and say, yeah, they cleared.
And the reason this became a problem is that what you don't realize that when you contact the ME's office from the scene, you go through a direct line, or do you call through Crescent? Yeah, and that's the automatic thing. The family and the funeral home have to go through, they don't go through Crescent, they have to go through another line. So when they call, they would wait. I called through the regular line to the ME's office, said, call me back. After a week, I hadn't heard.
The body's eating, right?
And so I called again, left another message, and then, 4 days later, I still hadn't heard anything back. So I went directly to them and talked to them. Now, they were making all sorts of jokes about who's really dead around here in this office and things like that, but, it was probably inappropriate. They make the same kind of bad jokes that we do. Okay, case number 1. Party to an unconscious at large corrections. Informed en route that CPR is in progress. This is a 42-year-old male playing basketball for an unknown period of time. Other inmates had informed the staff that he'd been sitting and breathing heavily, seemed distressed, and then collapsed. Staff checked in, found him to be pulseless, and started CPR. And they have an AED there. AED was applied and delivered 1 shock. CPR was started at 1300, defib occurred at 1305. On medic arrival, staff said they discontinued CPR because the machine said check the pulse. No shock advised. Patient supine on the gym floor, unconscious, occasionally moaning and flailing, radial pulse present. Initial EKG shows sinus tachycardia. Ventilation is assisted by a BVM, OPA, 100% O2, has the gag reflex, wouldn't accept the OPA, kicked it out. IO, right proximal tibia. CBG was elevated slightly, called an adrenaline response. Crew member sent to the ambulance to receive meds for RSA, tucked that away. Upon crew member return, patient given 150 milligrams of ketamine, 200 milligrams sucks, intubated 1 for 1. Life flight requested due to remote location. 12 lead EKG shows sinus tach without ST segment elevation. ID was then established in the left hand. Given an additional Versed prior for bucking the ET2, handed off to life flight. So here's the countdown. So 1326. Remember, it was 1305 that he had the shock. I mean, that's a long way out there. Extremely diaphoretic, 100% or is it at 15 liters per minute? EKG sinus tax, IO done, pulse ox 100% on O2, CO2 35. You've got all sorts of things to measure that, keep it going. Blood pressure 138 over 104, 104 pulse, respiration's 21. got some midazolam, pulse ox is still good, and then decides to intubate. So ketamine 150, succinylcholine 200, ET tube 7.5. CO2 value after intubation is 48. Then that comes down to 41. At 93%, no, it was 98% on O2, so that's pretty close to getting 99 to 100. And so decrease the oxygen a little bit, so 93 is not bad. We're aiming at 94, especially post resuscitation. IV is given, he gets another midazolam 2.5, pulse ox 94, perfect now, got some midazolam 2.5, CO2 is now 37, 97% O2, perfect, and then put him on the rig and fly him out. There's a 3 lead, I don't have a 12, didn't have a 12 lead on that, that's my only complaint about the documentation. This chart was reviewed by Dr. Fedor, and he's very nice. The chart's very well documented, describes the scene as they saw it, as well as describes what happened prior to arrival. Fortunately, the jail staff were able to do by-center CPR and defibrillate. The crew recognized this patient was not going to be waking up, wasn't protecting his airway well, hence the elevated CO2. A decision to RSI was appropriate made, tube was passed on the first attempt. Post-intubation care was great, repeated doses of midazolam was a smart move. I also would have, because he's bucking the tube, we've given him 3 doses of midazolam at that point, I would have thrown some fentanyl down on tube, because he's bucking the tube, partly because it's irritated. Someone had to go back to the ambulance for drugs. Always be prepared to intubate when having a code. That's Dr. Fedor's comment. You know you've got a code. Post-resuscitation, your likelihood is you're going to have to intubate. So, have your stuff ready. Helpful to have a narrative description of the RSI process that helps us understand too. I'm working on some methodology of perhaps getting better recording of the whole process so that we can do QA and troubleshoot some things and help people. And we still have a number of missed first attempts. We still have a number of missed intubations. I can't tell by the chart, this is Dr. Burke, when life flight was contacted. I assume the handout was at 14:07, which is 20 minutes after the RSI, so I suspect, and he suspects that life flight had been called fairly quickly in order to get that. Clinical care was great. That's why we can, when the clinical care is good, then we can talk about style points, talk about the fine points of this, like whether you could have put some potential to the patient too. In the ED, 2 placement was confirmed. It was right at the tip was right at the canina, so it was moved back a little bit. But you had checked for bilateral breath sounds. You had bilateral breath sounds, so it wasn't the right right stem or main stem intubation. Initial EKG was questionable ischemic changes in the interleads, but that resolved the repeat EKG. He went to the cath lab. He had no significant coronary artery disease. Then went to the ICU, had a full hypothermia protocol, woke up, was perfectly normal, neurologically. Because he had gone into BFib, he was in BFib because the machine defibrillated him, and they won't do it unless you're in BFib. So they did an implanted defibrillator and sent him back to jail. You'd think he'd get a pass for that, right? Nope. Nope. Oh, it was law enforcement here. So, a very good case and a, code safe due to bystander CPR and an APD. Case 2. Unconscious patient found a 56-year-old female lying on her bed. 2 caregivers on scene stated the patient normally wakes up at around this time and is able to sit up and interact. They state that today they couldn't effectively rouse the patient and believe she is having problems with her COPD. State the patient's been retaining CO2. She would open her eyes to painful stimuli, breathing shallow. SpO2 was low on her own home oxygen via nasal cannula. The patient was also diabetic. Blood glucose was normal. She sat upright, had a brief improvement in mental status. The patient attempted to speak, but was unable to do so. She moved all extremities, attempted to assist responders with moving to the stretcher. She was lifted on the stretcher, secured, moved to the ambulance. Duonab was administered due to extremely high EtCO2 values and waveform quote off the chart. 12 leads showed no signs of STEMI or hyperkalemia, did have an improvement in SpO2, but mental status and work of breathing remained poor. Due to signs of respiratory failure, RSI was selected, induction agent and paralytic were administered. Once medications had taken effect, ET tube was passed to the cords, cuff inflated, EtCO2 waveform and numerical value were verified. EtCO2 was again very high. Minimal, if any, chest rise. Verification of proper tube placement was checked several times. Chest was squeezed by responders due to possible air trapping, preventing chest rise. Inline duonab was used. Patient oxygen saturation level improved. EtCO2 remained elevated with minimal visible chest rise. Pulse intubation sedation was administered ×2. On arrival at PH Southwest, patient care was transferred to RN, etc. So, blood pressure is 90 palpable, open eyes, response, oxygen 15 liters, blood glucose 117, GCS is 8, blood pressure 121 over 61. No ST elevation on 12 leads, CO2 is 93. Albuterol, ipratropium given, CO2, that improved great. Pulse ox is 91, CO2 is now 72. Blood pressure is 105 over 57. Etomidate given, succinylcholine choline given, intubated, BVM, put on a PEEP of 5. Midazolam 5 given, CO2 99. Blood pressure stays the same. CO2 rechecked 99, got some more midazolam. CO2 is 99. This seems to be an echo in here. Got some more ipratropium, etc. Pulse ox 94, CO2 99, blood pressure 102 over 60 at the end. Not at the end, but at the time of arrival at the ED. There is her tracing with a CO2. You can see her respiratory CO2 levels at almost 100, which is 99. Now, this is a good case. This is also a really good case, and one of the reasons that paramedics are trained to do RSI, despite what some states believe. To preemptively take over the airway of a patient before they lose it and die. The initial assessment and documentation are done very well. I like it that there is a narrative description of the intubation procedure. It adds a lot to the chart, adds a lot to us being able to review it. So, impress us with your narrative on the RSI process. Post-intubation seemed to be difficult, limited chest rise and high ETCO2. Having an ETCO2 waveform is reassuring the tube's in the right place. Bilateral breath sounds add the tube isn't too deep. You really need to be sure, put the laryngoscope back in and be sure the cuff is still below the cords. Troubleshooting was great. Squeezing the chest for possible air trapping was a smart move. No, not over squeezing, but that's a technique that does work. Use of the med-neb is also clever. Now, what we saw, we didn't see a lot of waveform originally. I'm curious if there was an obstructive pattern to the waveform, i.e. a sharp fin. I don't see it on the quick snapshots. If you truly can't get much chest rise and the patient isn't ventilating, you need to increase ventilations. A rate of 12 probably didn't get a great minute volume with the limited chest rise. So what you do is decrease volume and increase rate. In the hospital, the tube placement was confirmed. Last scope, the tube is in appropriate depth on chest x-ray. She had multiple instances of desaturation in the ED, which responded to deep suctioning. A CT of the chest was performed, which didn't show anything significant. They're looking for PE. At the ICU, she was diagnosed with hypercapnic respiratory failure, meaning her CO2 had climbed over time, resulting in her ultimately being unable to compensate. This is felt to be due to non-compliance. That's why her CO2 actually went up after her O2 saturation went up when you gave her oxygen, because the only thing driving her was her oxygen demand. Normally it's your CO2, your rise in the CO2 that makes you breathe. And the low oxygen is your backup. So when you give them high oxygen, they hypoventilate then and the CO2 flows again. So this was felt to be due to non-compliance with their medications and her nightly CPAP. Now, the interesting is we had two caregivers at the home, so I'm not sure why they were allowing her to be non-compliant, but that's another case. She was extubated a couple days later, eventually discharged 6 days later, so you'll see her again.
Can I add something?
Yeah.
The other thing that I wanted to add that this crew, I suspect, clinically did really well is that they made the intubation go quickly, because you got a patient who's building up CO2, they're super acidotic, they're really, and then you paralyze them and then they stop breathing and they get more acidotic. So these are patients that are at really high risk of going into cardiac arrest when you paralyze them. And so you're absolutely forced to intubate them. But the fact that they did that so efficiently, got the tube in, started ventilating her, it speaks to really good work with the RSI.
And also really good to put the PEEP on her after the fact. So, I mean, she would have been an ideal candidate. Well, she wasn't an ideal candidate because she couldn't cooperate, she couldn't participate in her own care. I mean, for CPAP. I mean, so, all right. This is an interesting case. Talking about our psychiatric case. This is not a case that you want to send to an alternative facility. Dispatch code 3 to stage of a violent patient, possible drug overdose, called to the scene, code 3 by VPD after they arrived. Scene is an apartment. Several people are standing around outside the hallway. Patient is in the apartment, handcuffed with several VPD officers holding him down. Patient's fighting them. Due to space constraints, patient is carried out to the hallway, placed on the stretcher. Handcuffs are removed and soft restraints placed with all seat belts. Patient continues to fight. Skin is hot and wet. He will not answer any questions. Sedation is elected as Versed is being administered. Patient stops fighting and is unresponsive. This is not a result of medication and has not had time to take effect. Move to the MICU. Breathing is becoming slower and shallow with snoring. O2 sats is dropping. He has no response to Narcan. O2 sat improves with O2. The ETCO2 is very high and soon respirations are no longer adequate. RSI is elected. Patient ventilated by BVM during RSI setup, then intubated. Intubation verified and reassessed following each move of the patient. Family states patient has a history of, oh, big surprise, meth, alcohol, and opiate use. He was acting crazy and violent tonight, so 911 was called by the family. The sinus attack to start with got 10 milligrams of midazolam IM because they couldn't get an IV in him, which makes sense. Now his pulse ox was 89 on O2, CO2 was 64, pulse 122, pulse ox 98, CO2 is 64, blood pressure 104, pulse ox 97. Naloxone, no change. BVM, succinylcholine, ketamine. Presume he got the ketamine before he got the succinylcholine. It's just the way it's printed out here. ET2, 1-for-1, 7-0, successful. It was verified by Dr. Reed and the ED. Pulse ox 98%, CO2 74, midazolam 5. Patient reassessed, tube in place, yes. Okay, so there's his SpO2, his CO2, and his sinus attack. Interesting case. Happily, everyone was able to get safely manage this person. Good job to get the patient to the gurney, which is much better place to try to intubate and manage him. Switching to soft restraints early was a smart move as well, and I will emphasize that more in a minute. Decision to intubate was a good one. His respiratory status was declining in front of the crew. Great job overall. It's one of those cases that can be tough because you don't really expect to have to tube somebody for this kind of call. I can disagree with because we have a whole list of people who fit into this uncontrolled rage / excited delirium that end up going into cardiac arrest. So we do expect bad things to happen. Dr. Fedora would like more description of the RSI procedure, step-by-step oxygenation, environmentals, why certain decisions were made. There's only one blood pressure document on this entire call. This was taken about 5 minutes before drugs were pushed. It's not acceptable. Ideally, you'd like another one right after. You'd like one before pushing meds and one after. With this BP and a high heart rate, he would consider lowering the dose of the induction medication. The succinylcholine is perfectly fine. I think the ketamine dose is probably okay because, as I recall, his blood pressure was actually falling. If anything, ketamine is going to maybe keep his blood pressure up. So, but whenever anybody is driven by adrenaline like this guy, you need to get a blood pressure after you put the medication in. 702 was used. That's pretty small for a normal sized guy, and this was a normal sized guy. And 80 is probably the best for a normal sized male. Chart basically stops at the RSI. We don't know what happened afterwards. We presume he had a stable thing because he got to the hospital. In the ED, however, he was hypotensive in the 70s. He had metabolic acidosis, big surprise. Negative head CT, negative chest X-ray. In the ICU, he developed mild rhabdo from all the muscle activity. an acute kidney injury from the rhabdo, treated with IV fluids. He was extubated when his mental status began to clear. He was felt to be entirely due to polysubstance overdose. He was discharged home 2 days after being extubated. Now, this comes very close to being, you know, is this just polysubstance, is this drugs, or is this excited delirium? You know, because he responded excessively to the Versed, I wouldn't have given him any more of anything at that point. But if he continued to be violent and uncooperative, I would have considered giving him a dose of Haldol as well. But in this case, it was wise to, you know, when he started to quiet down immediately, that's a danger sign. Something is going to go on. Yeah. I've had 2 cases, and I didn't bring them to discuss, because I'm still waiting to get the stuff from the trauma people. One of the trauma surgeons contacted me and said, hey, I've had 2 cases in the last 2 weeks of trauma entry patients being brought in, one handcuffed to the gurney and one handcuffed to his wrists. Our orders say no one gets transported in your ambulance with handcuffs on. You replace them with soft restraints. If you need to use chemical restraint along with it, fine. The one patient gets to the ED, handcuffed to it, and there's no cop. And nobody can find the key. Okay?
Never one when you need one.
Never one when you need one. And this is kind of typical of, in my experience, this is kind of typical of the state police. They won't necessarily show up. Now, unless you can get the cop in the back of your car, of your rig, and come with you, I don't want them in handcuffs. That's just too dangerous, because you can't, how are you going to get that person if the guy starts vomiting or having, how are you going to get to that person? Now, the other one, handcuffed like this, no one could find an IV start. You can't do that when you're handcuffed. So, let's not do it. So your orders are minimal level of restraint necessary to ensure patient care and safe transport. Avoid placing restraints that preclude evaluation of patient's medical. Place patient face up on long backboard or gurney, not prone. Monitor respiratory status. Secure all extremities, ankles, and then wrists and arms to gurney or long backboard with soft restraints. No handcuff chains unless police in attendance. Now, do they ever ride in your ambulance? No. They almost never do. Secure long backboard. May use cease-point precaution to control violent head or body movements. Always evaluate respiratory cardiac status. Do not tighten chest straps, and use your chemical restraints as needed. The surgeon, and I don't agree with him on this, he said he would rather, if you had to, he would rather see you paralyze and intubate the patient. I don't agree. That is not the deal. You do not have to do that. You have good chemical restraint. I'll let Marlo, I'll let Dr. Mock deal with this one, this particular case, because he.
So this is our last case, and this is a case that I reviewed. Oh, sorry, So the crew was dispatched to a trailer park, and patient, bystander was with the patient, got his neck, so he got stung by a bee, told bystander to get his EpiPen. Bystander didn't describe any hives of redness, friend assisted him with his EpiPen. The fire department reported the patient red to the face, gasping for air. So an IV was started. They also gave epinephrine. On an initial ambulance crew arrival, he was screaming, yelling incoherently, he wouldn't answer questions. And then so the patient then calmed somewhat, said yes, your headache, did express a willingness to go to the hospital. Then he became agitated again. Maybe took his seatbelt off, left the ambulance, baked some pot, and then he says he doesn't remember, and then he's now saying, well, he has a headache, but he always has a headache. At this point, he was denying shortness of breath, itching or hives. He does report a history of anaphylaxis, the bee stings. There's the initial description. He initially ran out of the ambulance, then did get back in under his own steam. So here's the timeline. In 1938, epinephrine was administered. It's epinephrine 1 to 1,000, 0.3 milligrams. It was given IV. The vital signs is noted. The patient also got Benadryl. So I do agree that this patient probably deserves to come to the hospital and get evaluation, and I admire the fact that they were ultimately able to get the patient to the hospital. It sounds like this was a really difficult patient to deal with, and that can complicate the situations. And then the feedback that I would give, obviously, there is medication error, which I think is more likely to be with an extremely difficult patient. But also, I would, in general, patients having anaphylaxis rarely get out of their ambulance and then come back in. And this is someone who's not showing, he has tachycardia, but he's not showing other signs of anaphylaxis. There's no description of airway edema, no description of difficulty swallowing. Patient has a complaint of headache. And so it's just you trust your judgment and step back and ask, do I really need to treat? And then if you need to treat someone like this, if you're using an epi drip, then you have the ability to titrate it. Is there a question?
Yeah, but is this individual approximately a 40-year-old male?
Yes.
All right. So he's kind of a frequent flyer. I picked him up in Woodland before, and he likes to go into Oregon now. He'll do the same thing every time. He'll use epi prior to arrival, saying he has a severe allergic reaction. He's been in cardiac arrest from anaphylaxis and whatnot, and he's got his e-cigarette pot thing, and he won't go to the hospital unless he can smoke it before getting into the ambulance. So it's definitely, he doesn't, his throat will be clear, tongue will be normal. I mean, he has no signs of allergic reaction other than a little local redness where he says he gets stung. And other than being tachycardic, he's completely fine. But he does get really wound up, and he can be aggressive. Last time I took him in, he was discharged from the ED before I even cleared the hospital.
Yeah. So in this incident, arrived at 8:16, requested discharge at 9:22. He was quite tachycardic, and pupils were dilated on arrival. Seen by us 4 days later, and then was seen at Emmanuel the next day. So a difficult individual, but I would just encourage you to use your clinical judgment in deciding whether to treat, and don't hesitate to involve medical control if there's a question.
And the point I don't want to miss on this, because we've already dealt with the medic involved, is that there was a sort of a brain fart in being able to administer the epinephrine He felt that epinephrine was indicated. He had drawn up 0.3 of 1 to 1,000 to give IM. And then after all the fussing around, an IV was started, and he said, oh, I've got the epi, so I'll give the epi, and he gave it 1 to 1,000 is not to be given IVs. And there's nothing in your orders which tells you to give 0.3 epi push in anything other than a cardiac arrest situation, unless you're trying to create cardiac arrest. Now, I think this, I doubt very much from the description of the thing, I doubt very much that this gentleman actually has anaphylaxis, or he may have at one time, but not all bee stings are anaphylactic. I mean, some bees and wasps are different critters, and so they're not together. And I would, as Dr. Mock said, the nice thing about or if you really think that there's a potential of anaphylaxis, or that this is an allergic reaction, you really need to use epinephrine. It's 1 to 10,000, or it's an epi drip that you can titrate and have very good control. If you give anybody, and one of the other things about this case, and like I said, I already talked with the medic, is that if you make the mistake and give an epi dose like this, I want to see a 12 lead done after that. I want to see this patient monitored. I want to see, and we did have blood pressure, and the blood pressure was quite high, and the heart rate was quite high. Well, that's what epinephrine does. And the fact is, he's probably, his underlying status is probably where that is too. So, and like I said, you'll see him again too. Okay, last case. A little add-on only because I thought it was nicely done, nicely managed. On scene for a patient laying in the street next to the sidewalk on a southbound lane of, I'm not sure which. Bystander related patient was walking in the street when he was struck by a red car, which then left the scene at a high rate of speed. That narrows it down to several cars. Bystanders are unable to estimate the speed of the vehicle, only to relate the patient struck the hood and fell off the side of the vehicle and then was still. While approaching the scene, one individual expressed the patient's unconscious and has, quote, vaginal breathing. Patient's right leg is bent toward the anterior, above or just below the knee. Patient's heel is approximately 6 inches from his face. Yeah, no one at the scene has any information the patient can identify him in any way, and he doesn't have any ID on him. He did have a prescription from Southwest. Found approximately 65-year-old male lying his right side unconscious and unresponsive, skin's pink, warm, and dry, bruised to right forehead, $quarter size avulsion to right cheek. Pupils left eye open and clouded, right eye closed, non-reactive to light, no JVD, trachea midline, no step off, chest expansion equal, clear, silver dollar size abrasion over sternum, 10 by 5 centimeter abrasion over right flank, ribs feel intact, abdomen soft, non-tender, pelvis is rigid, non-tender, back non-tender, open fracture to right elbow, abrasion to posterior right arm, cast to right lower leg, just inferior to knee. Not very much intact. I mean, bleeding from surgical dressing at right knee, apparent tib-fib fracture just inferior to right knee. Bleeding noted from both right limbs, combined in about 250 cc blood loss estimated. Rapid trauma assessment, BVM-assisted ventilations. IVs done 900 cc's by the time of getting to the ED. Transfer to code 3 trauma team activation. Sinus tach, heart rate 128, SpO2 98, respirations 12, BVM-assisted, CBG is normal. Prepare for RSI, pre-oxidate, administer 20 of etominate. It's an amazing number. 112.5. That's the renal compulsive cannabis dose, 5 mg/sed, patient relaxes, suction blood from airway, visualize cords with keen vision, pass 1 for 1, 7.02. You notice that all of the intubations that we talked about today were 1 for 1. First pass. CO2 at 26. Patient is stable, arrives to the ED. So, this was a great job getting him rapidly packaged, rapidly intubated, while in transport. He had skull fractures, subarachnoid hemorrhage, multiple facial fractures, re-break of his tibial fracture, which had been surgically repaired at the about 2 days later, or earlier. He had signed himself out, AMA, and he was been sent, they had arranged for him to have several days stay at a hotel, but we don't know whether he ever, I don't know whether he ever showed up to that. He had signed out AMA because they wouldn't let him smoke. He had multiple rib fractures, multiple lacerations. He was moving all four, not following command, agitated. CT and MRI indicate diffuse axonal injury. Nothing. The subarachnoid was not a massive. It's just from the fractures and from oozing. So we're sort of watching and waiting. He'll probably stabilize. If he doesn't improve, he'll end up in a SNF. Because this is a really, really good job of managing a major trauma. Despite the minutia of the medication dose. Okay, remember next month is going to be, we're going to have 2 steps so we can go over the new protocols.